So now I'd like to introduce our last speaker. Dr. Maheen Mausoof Adamson is a clinical associate professor of neurology at Standford School of Medicine and clinical research director for rehabilitation services at VA Palo Alto. Dr. Adamson completed her undergraduate degrees in neurobiology and women's studies at the University of California, Irvine. She completed her PhD in neuroscience from the University of Southern California and a postdoctoral fellowship in psychiatry and behavioral sciences at Stanford School of Medicine. Please join me in welcoming Dr. Adamson.
Okay, how's everyone doing? Yeah? Everyone get some food, but please don't go to sleep. This can get boring, but I'll try to liven it up a little bit. So, I was just introducing myself to somebody who's sitting right in the audience from the Flying Tiger, and she said, "You can't ever have a memory problem because your title's so long." It is. It's very long, right? So, wanted to introduce myself particularly because it tells me and you about my expertise and why I'm here. And of course, because I work for, hopefully this works. Oh, I have to point here. Okay. There you go. So, I have some disclosures up front. One of them is that the opinions that I'm going to give you today are the opinions of my own. Stanford University or VA Palo Alto have no say in it, neither do the Department of Defense. I have other disclosures because I represent some companies that work with VR, but I have a much bigger disclosure. And that is that I have never served ever. I've not been in the field. I don't know how it is. So if I say something wrong, or if you see something too academic and too driven by science and doesn't have, I don't know, that feeling that I felt when I heard Bill Green speak, I apologize for that. Because what I heard here before the break, I don't know if I can even match any of that with my presentation. So, number one, thank you for your service, and I hope that I can contribute to it. There you go. So we're going to talk from the perspective of traumatic brain injury, because I'm a scientist who studies when the brain gets damaged, what happens to it. And this is the key point, because when you actually survive an attack, you can leave physically and you're alive, but you carry a lot of weight from that. And by weight, I don't mean particularly things that happen in the brain about memory, about stress, about fear. It's also physical damage. So it's an interaction of both the damage you have in your brain and then the feelings that you come out of it. So we're going to talk about how getting hit on the head can actually interact with the feelings of post-traumatic stress. We're actually also going to talk a little bit about the biology of fear, what happens when you face a threat, and how you either run away from it, or you avoid it, or you re-experience it. How does that work in the brain? Explicit versus implicit memories, and I wasn't done. And we're also going to talk about individual differences, how things are consolidated, and what you can actually be part of in terms of treatments. So we know already that there is traumatic brain injury. So maybe I should just say next, and you can just do next, yeah. So we already know that traumatic brain injury was a very big thing, started in Iraq and Afghanistan in terms of, because people were not in Vietnam, the way we understand it as scientists, is that the medvac could take you from the field, and you would be, a lot more damage would be done to the brain, severe brain injuries would happen, and then medvac would take you outside. As the technology improved, science improved, medical technology improved, people were taken away from the field earlier. So you had less severe brain injuries, more what's called mild and moderate brain injuries. And what happens with that, and what happened with OEF and OIF and Operation New Dawn, is you started seeing a lot of veterans who had these mild and moderate traumatic brain injury that was associated a lot with post-traumatic stress, depression, pain, fatigue, sleep. So you can go to the next slide. One of the reasons why that happened is because a lot of these military men and women were in what's called blast. And this is also relevant to the Vietnam War. What happens to your body when you know that there's a blast happening? You run away from it. So there's the slide that's circled in red. What it shows is, if I can read it correctly, a person can run about 22 feet per second away from the blast. The blast is coming at you at 26,400 feet per second. You're not going to win, okay? You can run away from it, you're not going to win. And what happens is blast is coming both from the ground and from the air, and it's affecting your brain in ways inside the skull. All of us have fallen on our head. Our skull is really tough. That thing can take a lot. But when you having these waves come in, it can change the direction, and what happens? Go to the next slide. So that's what we call diffuse axonal injury. First big word. Everybody has to be awake. Now, what does that mean? I myself didn't know what that meant about 10 years ago. I was like, what is this? It's your white matter in the brain going. Take a piece of cloth and take a scissor and cut it. It cuts very smoothly. Take a piece of cloth, put it in your teeth, and tear it. What happens? Both sides get these jagged looks. That's what's happening to your brain. Blast wave comes, boom, shear, and you're literally shearing your brain. It's called diffuse axonal injury because you're shearing the brain. So you can keep going. One more. That's a slide on how it looks inside, micro look at what it looks like. So you can keep going. Now, why do I talk about this? Is because you have PTSD, and I should call it PTS. This is an older slide. And traumatic brain injury share a lot of things. What do they share? They share irritability, cognitive deficits, insomnia, depression, fatigue, anxiety. Anyone who wants to study one thing, just study rats. Don't study humans. We all come with a lot of different things as we grow older. So this exactly here tells you the kind of different symptoms that we have to target in order to study. And your brain is the basis of all this. You can continue. Bill Green said numbers are boring, but I gotta put them up, okay? Numbers are not boring. To me, numbers are everything. So I stand corrected. So about 6 out of every 100 people, 6%, they have PTSD at some point in their lives. About 15 million adults have PTSD during a given year. About 8 of every 100 women. That's a lot. That's 8% develop PTSD sometime in their lives. Operation Iraqi Freedom, that's what I was talking about, enduring freedom. 11 to 20 out of every 100 veterans who served there had PTS. Gulf War, 12 out of every 100. Vietnam War, 15 out of every 100. And the recent study showed that the National Vietnam Veterans Readjustment Study, it's 30 out of every 100. 30% have PTS. Yeah, those numbers are huge. So let's go with that. What's happening? What happens to the brain when you're having PTS? I know that this is a complicated figure, and I made this. You know when I first presented this figure? This is an exciting story. Entertainment science industry in Hollywood invited me to talk about biology of fear because they wanted to include all that in a film. So this slide is from that. So I wanted to put that in because, I wanted to show that I can actually talk to entertainment people too. So the funny thing is, the brain to me looks like a fist from the side. So if you look at the fist, just on my hand, the shortest route of having any kind of stimulus. So if I see a threat in the environment, the shortest route is to go through my sensory system through the middle of the head, which is where the amygdala is. If there's one word I want you guys to take home today, it's called the amygdala. It's the area where emotions are centered, and that's the shortest route of any threat. You see a threat, the shortest route is boom. You know how they say flight and fear and all that? That's through that center, that amygdala. It can be, you can go to the next slide. This is a great slide. You can read it. It's funny. It's from the perspective of the dog. And what it says is, watch what I can make Pavlov do. As soon as I drool, he'll smile and write something in his little book. That's me, right? I'm always doing that thing. So. But I think what I wanted to get across to you is that there are some behaviors that we have that we just can't change because they're innate in us. If we see a threat that we have been threatened by it before, it goes through the shortest route possible through the middle of the brain. If it's something that is learned, it'll take the longer route. So you can go back the slide, not forward, go back. That's the long route. That's like memories, things that can engage you and go through your head for a long time, you know? Like I was listening to Bill Green's talk, and he was showing pictures of how he looked 50, how he had gained all this weight, and he was talking about that, and that's important to me because I talk about my weight all the time. It's a huge issue. So, but it's that aspect of memory building. Some of it is really, really good, and some of it is not that good. Some of it you want to let go because those are memories that hurt you, and that's the long route. It's from the cortex, from the top of the brain. So this part, it's like starts making all these assumptions about what you should be directing your behavior from. So you can go to the next slide. And somehow, when you make those associations with things, you reinforce your behavior. So it's like, oh, this worked last time when I saw a threat. So I made an association with those two things, and that's why there's a cartoon for the Pavlov, and I'm going to keep doing those things again and again. So it's hard to break those associations. So you can keep going. You also have something, some people may know this or not, but you're also born with a set of genetic susceptibility. What that means is you're born with a set of genes, genetic product, that may make you susceptible to having more PTS. This is a very important, there's research that's being done right now in a lot of companies, and it's kind of like whether you're colorblind or not. If you're colorblind, then you're not going to be given a job that requires a lot of distinguishing between colors. If you have a genetic predisposition to being more, having more problems with stress and having more problems with PTS, you should not be allowed to do things that cause a lot of stress. So there is a genetic component to PTS as well. So you can go to the next slide. So I had talked about two things. One was the amygdala, which is in the middle, and the other was the cortex. How do we take care of PTS? How do we make those treatments? How do we cure or treat people of this thing that's happening in so many 30% of Vietnam vets? And it's just staggering because it does affect the environment, it affects the society we live in. So if you wanted to get to the middle of the head and you wanted to treat something in the amygdala, it's very hard to do. It's hardwired. It's very implicit. It's difficult to do. It's difficult to break those connections. What's easier to do is the more explicit one, the one that goes from the top of the head, from the cortex of the head. You can really think about how you can break those connections and make you do what's called behavioral training, so you don't do the same thing you did when you see that threat. You don't freeze. You don't become aggressive. You don't hit the next person. Those are all symptoms of PTS. So how do you break those connections? Keep going. This is data from my own lab. So what we do is we find out how, well, in order for us to treat a problem, we need to figure out what the problem is and how can we look deeper in the brain to figure out where you can treat. So we actually take MRI scans and we divide your white matter tracts. So brain is made of gray matter and white matter. So we look at it separately and we divide them by different sections of the brain. So you see how in the middle of the brain there's that red tract that's going to the amygdala. You've got tracts that are going on the top. So we can look at them individually and say, aha, let's look at this area and figure out if this person has PTS. Has lower than if the tract is thinner in this person versus a person who doesn't have PTS. So things like that. So we need to first look at what the brain looks like. So that's what our lab does. Go to the next slide. We also then look at how your blood response are in the brain. So those wonderful colors on top of the brain that look like blotches, that's blood activity. So we can actually look at how blood is on top of the brain in someone who has PTS and versus someone who's healthy. And if you have some kind of altered response, we know that we can actually use that for targeted treatments, whether we can coach you in better occupational therapy, better exposure therapy, all kinds of different therapies. So I think that's the key here. So you can keep going. We can also what's called edit memories. Now I know that this sounds a little spacey and maybe going back to some, Blade Runner kind of stuff, but that's one of my favorite movies, by the way. So you could actually edit memories. Now what does that mean? What that means is, again, going back to that graph about Pavlov's dog, break that connection, edit your memory, make sure that it doesn't create that response from the threat that makes your life be put in a negative space. So we have in our lab lots of rehabilitation innovations going on. So you can go to the next slide. This actually shows that if you treat the brain with magnetic stimulation, you can change the way the function of the brain is, and at the same time change the way the mood is. So you can keep going. We also do virtual reality. So one of the things that happened in pandemic is we had all these veterans at the VA hospital. They couldn't come in for their pain treatments. They couldn't do their occupational therapy appointments. They weren't able to get any therapies because everything was shut down. So we started thinking about how could we reach our rural veterans or veterans who are far away. How can we reach them? It's not just on Zoom. I mean, how do you do a neurological exam on Zoom? Anyone thought of that? How do you do physical therapy on Zoom? You can't do that. Raise your arm like this. That's not going to work. So what we decided to do is we decided to team up with these awesome healthcare companies that are willing to give us these headsets. Of course, I have vertigo, so I still have never used them. So there's another disclaimer. I mean, I just do have vertigo. I'll throw up if I do it. So hopefully I need to do some kind of exposure therapy in order to get rid of my vertigo, but that's for another day. So this virtual reality is pretty cool. We can send you these headsets to your home, and you can sit in your home, and you can do these virtual reality exercises. Let's go to the next one. We did this one for pain. Now, pain and is people who lose function because of stroke. I have seen this happen. The reason I'm telling you this is because a lot of these symptoms are also included in patients who have PTS, but also if it works for one symptom, it'll work for other symptoms. That's my belief. So people who have stroke or people who have pain, usually when you talk to them, you're sitting across from each other and you say, raise your arm, and they'll say, okay, this much. And they'll say, raise your arm, this much. And say, I can't. Put them in a game and throw a ball up there and just watch them. It's so amazing to watch. Slowly they'll start, and after a few days of this kind of VR therapy, they're grabbing that ball. Because your brain wants you to succeed. Your motor area wants you to grab it. And so the pain kind of the therapy, and we were able to do this, and you can go. And we were able to show that there's a lot of ease and relaxation with this as well. I don't think there were a lot of people in there who had vertigo, and this is obviously much easier for younger generation than it is for older generation. Even I'm not very much into VR, so some people who are used to this technology, it's easier for them to do it, but I think older adults are also getting very much used to it. You can go. We also did a cognitive rehab task. So if you have memory loss, we put these headsets. We took the simulation of our patient room and we put it inside the headset. And then we said, hey, can you go and do, so this older adult is holding the VR and he's walking around this simulation and he goes and picks up pencils, then he goes and picks up this, and he's completing all these tasks. This is all done in a simulated environment. You don't have to visit the hospital. You stay home and you do it. It's a game you're playing, but you're playing it with your clinical providers, which is awesome, right? That's how you want to integrate, and that's how you get better therapy. Keep going. And so the VR therapies offer a big, unprecedented avenue for all kinds of research. There's also meditation apps in there. It's just a really big field that is really helping a lot of veterans gain their function back and have a better quality of life. So you can keep going. So I have 3 clinical trials going. I've been running around with my chicken, what is it called? With my head cut off like a chicken or something like that. And I'm like, oh, here, have my flyer. And we have this incredible lab, and you can go to the next slide. You can go to the next one. So I have this incredible lab, right? I have worked with a ton of people. You can slip. And you can keep going. So my team is huge. This is the people that I work with. They are incredible, and one of them is sitting in the audience. You can click on her name right there. That's Caitlin Chacon. She's my research assistant. She is a Marine, not an ex-Marine. I was just corrected. And and she has just joined our lab, and she's working very hard to recruit veterans for our studies. Gulf War veterans, we have Vietnam vets, and we're trying to introduce them to the new innovative research that we're doing. We're trying to bring them, as you say, bring them back home in an environment where we can provide them with the most amazing research that's done in Silicon Valley. And we are doing some absolutely amazing, effective work. So you can move forward a little bit. So I want to thank everybody that has helped me achieve all these results. We're very proud of our numbers. You can see our lab has done amazingly well. And that's it. Thank you very much. I didn't see anyone falling asleep, so I think I succeeded. Questions? Yes. No? You fell asleep. Yes, go ahead. Yes, I am. So I am a director for research at the VA Palo Alto Rehabilitation Service. So I manage all the research in the rehab. So I deal with polytrauma patients, TBI, PTSD, yes. So I'm a PhD in neuroscience, and I have a big clinical team. And we have clinical trials, and we see a lot of veterans who are patients, yes. Yes, of course. Anyone else? You can ask me anything, yes? It's being done in a lot of countries, yes, mostly developed countries because it's expensive. Europe is very ahead in it. And it's usually done for a lot of rehabilitation, stroke. It's done for pain, depression, mostly in developed countries and for those specific things. Meditation for PTS. But it's not very big in areas like South America or India. China is doing pretty well in it as well. Japan's pretty high too. They do a lot of VR technology. But Europe is really, really getting better at this as well. Yes? Yes. Oh, wonderful. That's a very good question, and I met you earlier as well. Thank you for your question. The short answer is no, but there are other therapies available that may stimulate that area. The magnetic stimulation that I'm talking about originally was started in the 1940s to stimulate the optic nerve, to increase the stimulation so you could see. But they weren't very successful. All they were able to show was like these wide, huge sweeps of white light. And that's it. But there are certain other ways of looking at it, maybe using ultrasound and also other kinds of infrared that can help. But my technique does not help with the optic nerve. I'm sorry. Yes. Yes. I could give you my card, yes. We can, if I can't help him, I can probably direct him to someone who can help him. And that's the, yeah. I will give it to you right after I get off the podium, yes. You're welcome. Well, I get to eat now. Thank you very much.